Hello, welcome back. For the ones who are seeing me for the first time, I would like to introduce myself, Dr. Roja, doctorate in nursing with the psychiatric nursing specialty. Please do subscribe my channel as I am going to release nursing related topics in a short duration on different subjects. Let's not waste time and let's straight away go into today's topic. Today we are going to discuss about nursing management of mood disorders. In previous videos, mood disorders part 1 and part 2, we have discussed about the disease conditions like mania and depression. And in continuation to that, we are going to see regarding the nursing management. And before we could go into the nursing management, we have one more condition like bipolar affective disorder. When we say bipolar affective disorders, it's like mania and depression being present in a person. And knowing about this bipolar affective disorder helps us to plan our nursing management well. So we will just have just small review of what is meant by bipolar affective disorder. Okay, BPAD, bipolar affective disorder. It is characterized by recurrent episodes of mania and depression in the same patient at different times. Maybe during one episode, the person might be suffering with mania, and after taking treatment for that condition, the person in the next episode will be suffering with depression. It might be at different times, and the duration of mania and depression varies. Coming to the signs and symptoms of bipolar affective disorder, we said we have maniac state and next one is depressive. If a person is in maniac phase, the onset is before age of 30 years, mood is elevated, expansive and irritable. Coming to speech, loud, rapid, punning, rhyming, clanging, vulgar language. Rhythmic words, singing, punning. Weight loss sometimes because they are overactive and they don't take time to eat food. That's the reason they have weight loss. Grandiose delusions, delusions of grandiosity, self boast. Please go back to my previous videos regarding mania. You will get a clear understanding of that. Mania with the psychotic symptoms, these delusions are present where they think great about themselves, easily distracted, hyperactive, decreased need for sleep because they are hyperactive and they have so many things going on in their mind. They don't feel like sleeping, they are restless, their talk is inappropriate, flight of ideas is present in them, begins suddenly and escalates over several days. Most probably this manic episode will be between 3 to 4 months. This same person, after taking treatment, the next episode he might be having depressive episode. If he is having depressive episode, how the mood will be: anxious, depressed and hopeless. Now you can compare this figure: elevated, expansive and irritable. Here the person is anxious, depressed and hopeless. Decreased interest in pleasure. You can check back to my video with the depression. Decreased interest in pleasure, I said it is an anhedonia. Negative views of life, cognition, perception, negative views of life in the aspects of self, negative perception of self, negative perception of environment, negative view of the future. The person will be having fatigue, that means lethargic, weak, tiredness, decreased appetite, constipation, because they don't drink, they don't eat. Insomnia is also present, because in mania also, there is an insomnia because of hyperactivity and restlessness. In depression also there is insomnia. In depression sometimes it can be insomnia or sleeping too much also. If insomnia is present, early morning awakening is seen, and because maybe they are depressed and they think too much, that's the reason they are worried so much, that's the reason they might not sleep. Decreased libido, that loss of interest in sex, suicidal preoccupations, may be agitated or have movement retardation. That means they doesn't show in doing any activities, for that matter activities of daily living also, grooming, bathing. This also is very poor in this person. Lack of communication, lack of social interactions is seen apart from these signs and symptoms which are presented here. This is earlierly known as maniac depressive psychosis. So coming to the episode bipolar mood disorder, according to ICD-10, we can say hypomaniac, mania without psychotic symptoms, mania with psychotic symptoms, mild, moderate depression, severe depression with psychotic symptoms, and severe depression without psychotic symptoms. We have seen mixed episode where mania as well as depression is present. So this BPAD is further divided into bipolar affective disorder 1, which is characterized by episodes of severe mania and severe depression. Next, bipolar affective disorder 2, it is characterized by episodes of hypomania. So hypomania, stage 1 we call it as what? Hypomania. And severe depression. So BPAD 1 and BPAD 2, BPAD 1 means severe mania and severe depression. BPAD 2, when they mention that, it is characterized by a person fluctuating between hypomania and severe depression. Now coming to other mood disorders, we have like mixed diagnosis. We said no, mania and depression being present at the same time in a person, or alternatively shifting, cycling of moods, we can see. Next, we have persistent mood disorders. Under persistent mood disorders, first, if you go back to my video mood disorders, I mentioned these two terminologies like dysthymia and cyclothymia. Dysthymia is persistently mild depression which is present in a person for a prolonged period of maybe 1 year, where they do not show any interest in pleasurable activities. And if the mood is shifting between mild depression and mild elation, maybe hypomania and dysthymia, it is called as cyclothymia. Recurrent depressive disorder means the episode of depression is already present, and the next time also the person again repeats an episode of depression. It is called as unipolar depression. Each time the person lands up with a mental disorder, he lands up with a depression. So that is called as a recurrent depressive disorder. Coming to the course and prognosis. Only one thing you have to remember, BPAD usually onset is a third decade, that means 30 years. Unipolar depression is common among two age groups, that is 5th and 6th decade, that means 50 years and 60 years. That means depression mostly seen after reaching an age of 50 years and 60 years. Then I have already mentioned, if it is a manic episode, it lasts from 3 to 4 months, and depression episode will be 4 to 6 months. And if it is mania, when we treat them with mood stabilizers, it can be controlled within 2 weeks. But whereas depression, it takes about 6 to 8 weeks. So I think you got an overview of BPADs. So now we'll move ahead with nursing management. You just take what all signs and symptoms we have discussed so far for nursing management. You can add it and it will make us very easy to form nursing diagnosis. So shall we go ahead with nursing management of mood disorders? Okay. Coming to nursing management of mood disorders, first one is nursing assessment for mania. We'll see for mania. You have already seen there is a disturbed speech, rapid speech, pressured speech, easily distracted, overactivity, mood, liability, irritability will be there, weight changes, and feelings of joy, sleep disturbance, lack of personal hygiene, lack of uh, like sleep, already we said, then altered nutrition, presence of delusions and hallucinations might be there. Basing on that, we can formulate nursing diagnosis. First nursing diagnosis is high risk for injury. High risk for injury related to extreme hyperactivity or impulsive behavior. Now, when we say high risk for injury, why is that? Because these persons are very much aggressive and they are like, so they are very much aggressive and impulsive, mainly related to what? Mainly related to alteration in biochemical factors. Apart from that, various etiological factors, lack of evidence to control their moods or their psychomotor activity, and because of that they involve themselves in risky behaviors like rash driving, giving away whatever they're possessing, or they become so aggressive that they go on to the other person. So they involve themselves in risk behavioral activities. That is one thing. Next, high risk for violence or self-directed or others directed, related to manic excitement, delusional thinking, hallucinations. If someone challenges them, if they say, I am a Karorpati, if other person asks them to prove, if they say, I am a Superman or a Spider-Man, whatever it is, I have a lot of powers, and if someone challenges them, in order to prove themselves, they harm themselves, or because of their delusions, sometimes they may attack the other person also. So first one is high risk for injury related to extreme hyperactivity, impulsive behavior, mainly because lack of control. Next one, high risk for violence, self-directed or directed at others, related to what? Manic excitement, delusional thinkings, and hallucination. Next one, we said these persons, because of their restlessness and anxiety, they cannot sit, take time to eat. So as a result, altered nutritional less than body requirement, refusal or inability to for a sit for some time and eat. So evidence by weight loss and amenorrhea. Next one, these persons have lack of social interactions, impaired social interaction, related to egocentric or narcissistic behavior. You know what is narcissistic behavior? It is narcissism is like self-love. They give priority for themselves. Narcissistic behavior, egocentric behavior, evidenced by inability to develop satisfying relationship and manipulation of others for own desires. Coming to, you can add other nursing diagnosis also for this. Altered nutrition is said, high risk for violence, high risk for injury. Apart from that, we said grooming. Then ineffective family coping also can be added for these persons. Care plan for mania, risk for injury related to hyperactivity as evidenced by increased agitation, lack of control. That's what he said. So outcome, client will not experience injury. Coming to nursing interventions, reduce environmental stimuli. Now, when we say reduce environmental stimuli, you have to provide safe environment. For any nursing intervention, please remember, you have to assess the condition of the person. Whenever you're planning a care plan for any patient, first gain consent from the person, assess the mental status of the person, then vital signs is a must, then you come for these interventions. Reduce environmental stimuli. When we say reduce environmental stimuli, it meant that we are supposed to provide harm-free environment. Remove any sharp objects, okay, from the environment. Assign single room and keep lighting and low noise, because already they are agitated and irritated, and if noise is more, it will try to provoke the person and trigger a person. So remove hazardous objects and substances. Stay with the client who is hyperactive and agitated. Provide physical activities, that means recreational activities. Administer tranquilizer medications as prescribed by the doctor. Provide psychological support when needed. Next one is risk for self-directed or others directed violence. So here also we have to gain consent whenever you are planning anything. Assess for the mental status of the person, client. Maintain low level of stimuli, that means calm environment. Observe the client behavior at least every 15 minutes. That means these persons who are very much agitated with either it may be mania or depression, they should be near to the nurse's station. Every 15 minutes we have to observe. As mentioned earlier, we have to remove all the sharps from the environment, client's environment. Redirect violent behavior, maybe by some involving them in some diversional therapies or recreational therapies. Encourage the client to express his anger verbally, ask him to say it out. And we need to have sufficient staff to store strength in case when it is necessary, when the patient becomes very aggressive and tries to come on us, we need to be sufficient enough to support ourselves and to face the patient. Then apart from that, we need to administer medications, mood stabilizers or tranquilizers as prescribed by the psychiatrist. And we can use restraints, that is the other alternative we have. And these restraints also, they should be used according to, like, verbal restraint is one, by use of voice. Then coming to the chemical restraint, that is by administering tranquilizers or tranquilizing injections and medications, etc. The last option is mechanical restraints, where we tie a person, and when we tie a person, we need to remember the rules what we have to follow while restraining a person, such as like tying the three extremities, and always we have to keep one extremity loose, and every 15 minutes we have to keep changing the restraint position, places. And also we have to see that we do not tie too tight. We have to observe for any cyanosis. Just check whether free blood flow is there wherever we tie. So all these precautions you have to take when you're using these mechanical restraints. Next, observe the client. Already mentioned, remove the restraints gradually, one at a time. Next, coming to other nursing diagnosis, impaired social interaction related to egocentric or narcissistic behavior, evidenced by inability to develop satisfying relationships. Outcome, client will interact appropriately with others. So what we need to do here, nursing interventions. recognize the manipulative behaviors, help to reduce the feelings of insecurity by increasing feelings of power and control, set limits on manipulative behaviors. Suppose if they are trying to manipulate other persons in the environment, or doing any other things like other patients manipulative things behaviors to the other patient, you have to set limits, like verbally, then chemically and mechanically. Explain what is expected and the consequences if they violate the limits. Whatever we have to set boundaries for them. Do not argue with the client, bargain with the client when he tries to argue. Give positive reinforcement whenever he just sticks on to the instructions we give, whenever he listens to us, and discuss the consequences of client's behavior and how attempts are made to attribute them to others. So you have to give positive reinforcement more, because that can change the behavior of a person in a positive way, rather than shouting at them or uh, setting too much, or like we cannot demand things on them. That's what we have to keep in mind. Next, coming to these are certain important nursing diagnosis and nursing interventions we have to take. And coming to the other nursing managements, we have nursing management of depression. We'll see regarding the nursing management of depression. Coming to objective signs and subjective symptoms of depression, we have objective signs like alterations of activities, psychomotor activities decreased in them, poor personal hygiene, apathy, then altered social interactions, then negative perception, that we already know. We have somatic complaints. They can complain that they're having severe pain, delusions and hallucinations present, and anhedonia, worthlessness, hopelessness, helplessness, and suicidal ideas. You all know that. Coming to the nursing diagnosis for mania and depression are a bit of similar, except for the thing that suicidal ideations are present in depression. Risk for self-directed violence related to depressed mood, feelings of worthlessness, anger turned inward on self. Client will not harm himself, suicidal ideations. You have to assess, gain consent, assess the mental status, as well as ask, do you have any intentions of harming yourself? If those are present, do not ignore, take them very seriously, inform the medical team, see that you observe the person closely and the person is near to nurse's station, remove all sharp objects, ropes, bottles, knives, and any means liquids, etc. It may be desirable, like you do not allow the person to bolt the rooms, so remove the bolts for bathrooms as well as for the doors, so that we really don't know when they get this idea of attempting a suicide. And apart from that, ask the person to verbalize himself, express, give time to the individual to express himself. Next, coming to nursing diagnosis to like dysfunctional grieving related to real or perceived loss. Evidenced by denial of loss. This happens when the person loses treasured object or a person. Anything where the person values more. Maybe I lost this because I was not present. If I was there, I could have saved, or I was helpless, I couldn't do anything. These guilt feelings will be more in this person. So, dysfunctional grieving. Outcome will be client will be able to verbalize normal behaviors associated with grieving and begin progression towards resolution. So, grief process. According to Kubler-Ross, we have different stages of grief: denial, anger, bargaining, depression, at last acceptance. So you have to assess at what stage of grief process they are fixed at. Show empathy and concern and unconditional positive regard. Help them to ventilate themselves and ask them what relation they have towards the object or a person whom they have lost. Involve them in recreational therapy and activities, outdoor activities. Teach them and educate them about how to behave during this grieving process and different stages of grief, and provide psychological support to the person. If necessary, refer the person to psychologist for interpersonal therapy. That would help them. The next one is self-esteem disturbance related to learned helplessness. Feelings of helplessness, hopelessness, worthlessness, negative perspective of life, negative view of life. So, self esteem disturbance related to learned helplessness, feelings of abandonment by significant others, impaired cognition, fostering negative view of self, evidenced by expressions of worthlessness, hypersensitivity to slight criticism, also, and a negative, pessimistic outward view. Outcome identification: client will interact appropriately with others. Developing a trust relationship with client. Involve the client with others so that he can interact with other persons as well as with the staff. Explore if he has any feelings of anger. Depression is something like anger directed inwards towards self will turn out into depression. So these persons can be like encouraged to participate in some activities where they can vent up their anger. Recreational activities. Provide simple activities. Do not involve them in competitive activities. Simple activities where they can achieve or gain some success or divert themselves, diversional therapies. And each time when they accomplish small tasks, also provide positive reinforcement or positive feedback. Explore, sit with the client on one-to-one basis, explore their personal strengths and weaknesses. Ask them to write their strengths and how to come out of the weaknesses. Let them list, and you have to sort out with the person. These are main things. Apart from these, we need to deal with altered nutrition. If they are maniac patients, what we are supposed to do? They don't sit, assess the nutritional status. We know it is less. Then it's better for them to provide finger foods, where they can eat items while walking, and ask them to take more fluids. You can provide them with small drinks, energy drinks for maniac patients. Same with the depression persons also. You have to plan out for meeting nutritional needs. Apart from that, altered activities of daily living. You have to make a schedule for them so that where they can accomplish their activities of daily living. Then family coping, ineffective family coping. So this is where family is involved, where you explain about the disease conditions of the person, action of medications, and drug importance of drug compliance, importance of recreational therapies for them, importance of involving them in diversional therapies, counseling, stress management. These are other nursing means important points where you need to remember in nursing management of BPADs. And this is all regarding this. If you have any other uh, means doubts, or if you would like to me to share any other things in detail, please put it in a comment box where I can share it with you. And thank you all very much for listening to me so far. And I would like to request you to please subscribe and share to others, because I am going to continue to share nursing related topics. If there is anything that you would like to suggest which makes this videos interesting, please do suggest in comment box. This is all for now. Thank you all very much. Bye.